Hello, everyone. Thank you for joining us today. My name is Kayla Magruder, and I am an admissions counselor here at Tulane School of Public Health and Tropical Medicine. Today, I have Dr. Washburn here with me. He is our MHA director in our Health Policy and Management Department, and today he's going to be providing you a public health discovery seminar series on community health workers and Latinx immigrant health access in the U.S. Thank you so much, Dr. Washburn, for joining us today. I will let you take it away.
My name is Dave Washburn. As Kayla mentioned, I'm the MHA program director here, the Masters of Health Administration, that is, for those that don't know the acronym, and also a clinical associate professor. And today I'll be talking about some research that I did a few years back, but it's turning out to be incredibly relevant again right now, actually even this week as Supreme Court decisions loom in the near future, allegedly Wednesday. We'll see what happens. But my talk is on community health workers and Latinx immigrant health access in the United States, specifically in Texas. The research I'm going to talk about today is a part of a wider series of projects that I worked on with a number of collaborators, generally at Texas A&M, where I was prior to Tulane. But today I'm going to focus primarily on this topic, which is a passion of mine. So a bit about me. Oh, and real quick, yes, we will have time for Q&A at the end. Please put your any questions in chat if you don't want to forget them, and I'll try to get through them at the very end. So a bit about me. I've lived in Latin America for a little bit over 6 years, about half that time in rural communities with limited infrastructure. I was a Peace Corps volunteer in Honduras, where I worked on gravity flow water systems. I also did some medical translation and a number of different projects. I also lived for a number of years in Mexico, where I worked and did my doctoral research on health insurance reform, specifically studying the implementation of the Seguro Popular health insurance, if anybody has heard of that, which was an effort to provide health insurance to about half of the population of Mexico in the early 2000s. Those that did not have insurance through either through being employed in a very large business, or working for the government, or working for the oil industry or the military, who all had their own sort of social health insurance systems. I've also spent some time with Doctors Without Borders, or Médicos Sin Fronteras, or Medicine Sans Frontières in Mexico, focusing on immigration in particular. I also worked on health insurance reform in Chile, in wait lists for specialty care. In Paraguay, I worked in an indigenous community, in a Guarani community, when I was much younger, many years ago, doing some sanitation and health work. And then also I worked in the Dominican Republic and Costa Rica on healthy stoves and rural teacher housing. So I've done a fair amount of global health work and projects, but I've worked domestically in the US healthcare system as well. I've worked at the San Francisco VA Medical Center at Stanford Hospital, that Stanford Hospital system, where I've done some capital and strategic planning, which is why I'm also an MHA director, which is largely focused on domestic healthcare in the United States. A bit more about me. I believe that health is a human right. I consider the failure of the US healthcare system to provide health access to all individuals within its borders to be a failure, especially in the most expensive healthcare system in the world, where we spend more as a percent of our GDP per capita than any other country on health, and yet we still can't seem to get access for all of those that deserve it, and I believe that everyone does, as it is a human right. I do see some steps that we could take, including the greater integration of community health workers, serving as patient navigators and also bridges between communities that lack access and the very complex systems that we have created. And I also believe that the increased utilization of value-based payment models could really be critical paths to build greater access and equity in the US healthcare system, especially when it seems like we lack the political will to pursue greater reform at this stage. But I am an optimist. Hopefully someday going forward, we'll be able to see something like that. But there are also steps that we should be taking anyways, including the greater integration of CHWs into our system. Here's some of the papers that I've worked on and I just wanted to thank all these collaborators before we get started. Tim Callahan, Katie Nimmons, Mercedes Ducicella, Ayub Guram, Jim Burdine, Kason Schmidt, Megan LaFleur, Denise Martinez, Emily Thompson, Zulema Ruiz, Denise Martinez, if I hadn't mentioned her already. I wonder if I mentioned everybody. I hope so. But all some wonderful collaborators. We worked on a number of papers in a series of different topics. All of those are linked there either through the DOI. That last publication is not peer reviewed. It's a policy brief that was created for the Federal Office of Rural Health Policy. We also had two different funding sources from Texas A&M, a seed grant that provided funding for some of this initial work, including the work that I'll be discussing today, and then also the HRSA Federal Office of Rural Health Policy provided us with some additional funding to pursue additional research. So just before we get started on the actual research, I wanted to bring this into context of some things that are happening right now. There are some really important things happening in Texas and the Supreme Court of the United States. Texas had passed Senate Bill number 4, and I'll refer to this as SB 4, which seeks to make crossing the border without documentation a Class B misdemeanor with up to 6 months in jail and repeat offenders facing a second-degree felony with up to 20 years in prison. It also requires state judges to return migrants to Mexico with local law enforcement responsible for the return. And I'll get into why this is so relevant to some of the research that we were doing in a bit. And under SB 4, local law enforcement could not stop someone because they presume a lack of immigration status, but they could ask in the course of enforcing other laws. And sanctuary cities, including cities like Austin, that previously had been able to locally prohibit the asking about immigration status in the course of enforcing other laws, would no longer be able to do that. So this has some pretty serious ramifications. Again, this is all things happening in the past couple of weeks as well. So on March 1st of just 2 weeks ago, or 10 days ago, U.S. District Judge David Ezra out of Austin blocked SB 4 from going into effect the following day. It was supposed to be potentially, I believe, that Saturday, saying that the law threatens the fundamental notion that the U.S. must regulate immigration with one voice. The following day, the 5th U.S. Circuit Court of Appeals, which is based in New Orleans, reversed that ruling by the district judge. And on March 4th, just 2 days later, the U.S. Supreme Court issues a temporary stay, so not allowing the implementation of SB 4 and the enforcement of SB 4 until they review it again, potentially this Wednesday. In 2 days from now, the U.S. Supreme Court will decide whether or not Texas will be able to enforce SB 4, in effect having their own immigration laws that differ from the rest of the United States, and for a number of reasons why I will be describing here in just, well, I'll be describing here in just a minute, may really lead to some various serious and harmful health effects for immigrants, mixed status families, and even U.S. citizens. So it's important to consider. The return to Mexico policy that has been utilized really since the Trump administration directly and adversely affects the health of migrants. I've spent some time in migrant camps in Reynosa, Mexico, where I worked a little bit with Doctors Without Borders, and hearing about some of the deleterious effects, or the harmful effects of the return to Mexico policy, where individuals upon returning into Mexico would be targeted by cartels and other folks, and sometimes at a higher risk of kidnap or knowing people who are kidnapped, being threatened with violence, just a number of harmful health effects, just because they were easily targeted upon return across the border. I've even seen this in some data that has yet to be published, but this has really created a number of very important and serious issues. And thankfully, there are organizations like Doctors Without Borders that are helping to mitigate some of the harm that has been done. But it is a lot. It is a lot to ask, and it's a shame to see it happen. I've also lived and worked in communities where many young people left to find safety and opportunity in the United States. I've lived in some communities where I heard gunshots every night. And I've also spoken with some migrants who left situations of terror and wish to seek asylum in the United States. And including some individuals who, over the course of the pandemic, a son who was really a moneymaker for a family in El Salvador, used to be able to pay off the every so often bribes that were required to not be in danger with, I think it was MSA 13 in that particular case, of having any harm from local gang members. And once they lost their job because the hotel industry was starting to fail during the pandemic, they were basically given the option of, well, you still have to pay somehow, or you have to come work for us. And then sort of that morning at 3 a.m, the son, his girlfriend, the mother, all left, packed a bag, basically left and ran as fast as they could, heading towards the border. So these are individuals that have faced a significant amount of hardship, and creating additional hardship really shouldn't be the business that we're in. I'm going to get back into the research here, starting off with there were 4 sort of research projects that I highlighted a little bit earlier. The one that we'll be talking most about today is the community health workers and access for underserved populations, particularly in the state of Texas, and as it relates to immigration in particular. I won't be discussing, but you can read this on your own if you want to look up some of the links that I provided earlier. A legal analysis of reimbursement mechanisms for community health workers. Just as to briefly mention, community health workers oftentimes are covered through grants for some of their work. And there are a lot of parts of the U.S. healthcare system that are looking to provide more stable reimbursement and job opportunities for CHWs that are really becoming seen as more and more critical in a lot of the navigation aspects, and also helping to build trust in communities of some historic distrust, and for a variety of reasons. So hopefully we'll see some more movement there. We also did a fair amount of work in Minnesota, California, Florida, and Massachusetts, looking at urban-rural differences in the work of community health workers. As we know, there are a lot of rural health disparities, and CHWs are very well positioned to try to bring communities together, but there are some additional challenges that they face, especially with reimbursement in rural settings. And then also some work on how do you integrate CHWs into healthcare teams? How do they begin working with providers, with clinical providers, with doctors and nurses and social workers, and how do you build that trust within an evolving team where we're trying to see more holistic healthcare teams in the U.S. healthcare system that also address the social determinants of health, which CHWs in particular are very, very well positioned to help to address those more than perhaps many other healthcare providers. Okay, so these are different kinds of research projects. Some of them were very qualitative in nature. The one I'll be talking about today is a qualitative research project where we ran focus groups with community health workers in a number of different sites in Texas. And some of the other research was focused on analyzing laws. We had a legal scholar that helped to, and with his graduate students, really helped to do a lot of that analysis. We also conducted an online survey, national survey of community health workers, and conducted focus groups also in those 4 different states that I mentioned to be able to look at urban-rural differences in how CHWs operate. Now, focusing on that first project, really community health workers and access for underserved populations in the state of Texas, and particularly the Latinx population. Just a bit of background: in the United States, Latinx populations make up about 19% of the total population, but they represent 40% of the non-elderly uninsured. So uninsurance rates are much higher in the Latinx population, and in the state of Texas, it is not an exception, where Latinx populations make up 40% of the total. They represent 65% of the non-elderly uninsured. And Texas is also percentage-wise the least insured state in the country. It's not expanded Medicaid. So we're talking about millions and millions of individuals. So access has been a challenge: access to insurance, access to clinics, and we're going to get down into something a little bit less sort of broad as access to insurance in general, but some of the day-to-day things that can affect people's access to health. So beyond insurance status, many barriers to accessing healthcare exist, including transportation, financial resources, of course, education, language barriers, and critically for this study, documentation status and fear. Community health workers, CHWs, as I've also been calling them, or promotores or promotoras, as you may have heard, you spent some time in Latinx communities or in Latin America, serve as bridge figures that connect vulnerable populations to needed care. Oftentimes, members of the communities they serve, their shared experiences and cultural competencies provide CHWs with the essential abilities of building trust and creating linkages between underserved communities and the complex systems navigated when people seek services. And just, think about, as a health policy and management professor, I sometimes have difficulties understanding my own insurance, my own health insurance, or my partner's health insurance. And what does it mean when we both sort of are within the same system, and actually have to talk to my own health insurance, my own benefits coordinators, because I think we're double covering my partner right now, even though I told them that they were going on their own insurance. So these are and that's somebody who has access to insurance, but it's still very complicated. When I go to, and I don't go to the provider nearly enough, I really should do this a lot more, but I hate waiting in lines, and I hate the fact that I might go to my primary care provider just to be told, well, go out and get these 3 tests and this scan and then come back to visit me again. Well, maybe I should have done that beforehand so you would have all the information right then, or maybe we could do all of those things the same day. And I'm somebody who has access to transportation, and I have access to financial resources and education, but there are still barriers navigating these complex systems. And one point that I just want to make relatively clear is that when you don't have access to all these other things, there is a multiplicative effect. There's a multiplicative effect of barriers that makes every other barrier a little bit worse when you're trying to navigate these complexities. And really, when you don't have an advocate, and you don't have sometimes individuals like the community health workers, when they can provide these types of services on your side, or if there are things like unnecessarily imposed fear because of politics, really access starts to break down. So we need to do a lot better here. But sticking back with community health workers here a little bit, there are a number of different definitions that I have seen for community health workers, but just one from APHA, a working group, has adopted the following definition, which I think is one that's perhaps more palatable across the research world that focus on CHWs. A community health worker is a frontline public health worker who is a trusted member or has an unusually close understanding of the community served. This trusting relationship enables the worker to serve as a liaison, link, intermediary between health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. A community health worker also builds individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, and advocacy. They're really bridge figures and oftentimes part of the community or having an unusually close understanding of the community served in APHA's words. Okay, so with all that background, sorry, and I know that's a lot, and with all this going on in the news right now, it kind of adds a little bit of a new slant to this. But our primary research question back when we were conducting surveys and focus groups with CHWs in the state of Texas was, from your perspective, what are the barriers to Latinx health access in Texas? Our methods for this qualitative study were as follows. We conducted 7 focus groups with community health workers, promotores and promotoras, to understand barriers to Hispanic health access in Texas. The focus groups were conducted in English and in Spanish based on respondent preferences. I do speak Spanish, so I conducted a number of them in Spanish, and my colleague Tim Callahan conducted a number of them in English as well. We conducted these in Dallas, Houston, El Paso, sort of larger cities, also in McAllen and the Rio Grande Valley on the border, and in Brazos County, Texas, which is more rural. This set of locations allowed us to study CHWs in major cities and also border regions and more rural parts of the state. The focus group questions emphasized barriers to health access for clients, how barriers vary across different groups, ways to overcome barriers to health access, CHWs' roles and responsibilities, and then the impact of the Trump administration policy efforts. 67 CHWs participated in total, and we audio tape, transcribed, translated into English when necessary before doing qualitative analysis using in vivo 11 with multiple coders. And we found a high level of concordance in our coding as well. So now I'm going to go through the results and just talk through a number of quotes that we heard from CHWs speaking about healthcare access. So this is a number of quotes from CHWs when talking about the work that they've done with their clients and some of the barriers to seeking access or seeking care in Texas. One of the barriers that was mentioned was feeling powerless. And so a lot of these quotes may not have perfect grammar. These are direct quotes, so we didn't try to change them too much. The migratory status right now is repressing many people. This week, a lady was diagnosed with breast cancer. What did the lady do when she detected? What programs can help this lady who has 20 years in the United States and no one can help? The doctor told her if she does not have the papers, they cannot help her here. She better go back to Mexico after 20 years. In those situations, one feels powerless. Who can help her? Right? And as we know about breast cancer, the longer and longer you delay, the worse and worse it can get. Another barrier that was, of course, discussed were the language barriers and also some of the barriers that come from word of mouth spread of information. For the Spanish population, I think a lot of times it's just to be able to get to speak to somebody who actually speaks the language. I know there's a lot of places that have a bilingual person, especially in Texas, but a lot of places do not have that person on that frontline phone. If one person comes into the clinic and they had a bad experience, it trickles in. They say, don't go to this place because they treated me badly. There was somebody there that didn't even speak Spanish and couldn't help me, or whatever the case may be. And then it goes out and goes around, so nobody trusts the service. I know that I'm constantly having to advocate for small media and educational materials in Spanish constantly when we are in Houston. I worked for a huge organization, and even within my own organization, I'm fighting constantly. So these issues aren't issues just in small rural towns, but even in large cities with huge Hispanic and Latinx populations. They're struggling at times to have the right materials, the right people being able to answer the phone, access to translator services. And these community health workers are seeing it. Another barrier that we heard of a fair amount was even a culture of health that can be a barrier. In the Latino community, we don't do preventative care as much. We only do sick care. We only go to the doctor when we're sick, not 6 months ago when I started getting a headache, wondering why my feet are getting swollen. No, until you did not go to work, or if you're not going to school, or you're in your bed, then we need to find a doctor. Maybe there's something wrong with you. Another CHW reported, I can tell you that in the Mexican community, we do not believe in behavioral health. So there are some challenges here, some historic challenges. And I think part of this challenge is also a lack of sort of relationships with places where preventative care or mental health care is easy and accessible, which also should hopefully make you think a little bit more about how these barriers can intersect, and a lack of history can lead to even more barriers going forward. All right, moving on. In this section, we'll talk about some of the quotes that had to do with fear and legal status. People are afraid to go to the doctor. The people who do not have health insurance or legal status here, they fear to go to the clinic. I have known people who are dying at home. They prefer to endure a toothache, stomach ache, than to be seen by a doctor. They say if they catch me and know my name, they will take me out of the country. So it's a promotor's work, and CHW, trying to change the mentality of people and then tell them what is our mission. They do not go to their medical appointments because because of the fear they have of moving because of their immigration status, augmented by their fear of the raids there are and the news. There are also people who, in order to enroll in the clinic, ask to have their registration card. People are afraid to do that process, to get the card. My husband says that if I take out the paper, they can deport me. Another portion to this section about fear and legal status, people made connections between going to the doctor and getting deported. And whether it was true or not, it was a perception in the community, and it has an impact on people's access to care. So locally, it's like, no vayas. Don't go to that clinic because the receptionist is known to call ICE on you or is going to report you. I went to some clinic, then I got a phone call, or then got a visit to my house or something, because these are all families that are at various stages of their immigration process. Either they have filed something and they're waiting to hear back from immigration. Then all of a sudden, they get a letter in the mail stating that is an order of deportation or order of removal. They start making these connections that, well, maybe it's because I'm undocumented, because I speak Spanish. There's a hyper-vigilance that occurs in our communities. So there are the rumors. They are very damaging, and it's another barrier to access healthcare. The fear of bureaucracy is being written down anywhere. In some circumstances, people even fear CHWs and promotores. Fortunately, they, community members, are afraid of us CHWs. When we went to the community that is far away from the center of where, I think this was close to the border, this particular focus group, and the people do not open the door, even knowingly. They throw the papers under the door, and you ask, but do we know each other? We go through the colonias, and people say they leave their information in the mailbox or the window. They hardly open the door because they are afraid. Now, some individuals that have documentation can go to Mexico to access care, even if they do not have insurance in the United States, but not everybody has this advantage. One of the CHWs reported that people who can cross into Mexico with documentation, they can access medical services, but many people do not have that luxury of crossing with the family. It may be that the children are citizens and the parents are not. That can be a barrier because of immigration laws in the state of Texas. With SB4, the immigration law that I highlighted earlier, people are afraid to go out on the streets until they go to the store to buy food. If a policeman stops someone, they're at risk of being deported. If they are not going to buy the food, they will not go to the clinics either. This is a great barrier. And so even at this time, SB4 was kind of in play, but it's been challenged and it's been tied up in the courts. And we're going to potentially find out in the next few days what eventually happens with it. Another thing that we heard when doing these focus groups is that the border is no longer the border in the state of Texas. The state of Texas is huge. The other thing to understand under Trump administration, the border is no longer the border that we used to know. The border is now throughout Texas, so the checkpoints are throughout Texas, and residents will avoid where checkpoints are, or will avoid driving altogether because they don't have a driver's license. Whereas previously, it was usually, a certain number of miles from the border is where a lot of the checkpoints were, and people would just know to avoid those. But then it became very amorphous, and people began to be afraid of driving in a lot of other parts of the state, including in northern parts. I believe this particular comment came from Dallas. Another point that I really want to make is that rhetoric matters. The words of the president have, at the time, had an impact. One of the community health workers reported to us, it was like a Friday. Trump was threatening to deport people left and right. That next Monday and almost the entire next week, our clinics, everybody didn't even cancel, they just didn't show up. They were terrified. Just because of some words that are put out through social media, on the TV, on a Friday afternoon, all of a sudden, all of those appointments, all of that scheduling for the next week just gets blown up. Now, sadly, also, when we talk about when there are vulnerable populations that struggle with access, oftentimes it's the most vulnerable within the vulnerable populations that are most at risk. In this case, children. So here's another quote from a CHW. When Trump became president, he said, if you are receiving benefits and you're undocumented, they were going to deport you. He was working on getting access to immigration status for people who are receiving public assistance, which is SNAP and not Medicaid. So a lot of people did let their SNAP benefits expire and could not feed their children. Their financial situation has not changed. It was because of the fear that their information would be given to ICE and that they would be deported. With the political climate in the United States right now with Trump at this time, the fear of deportation is huge, and it's keeping people from accessing care because, like she said, everyone in this room said because of fear. They are fearful that they have citizen babies, but the parents are, in their words, illegal. They're going to send me back. What can happen to my children? All right, so that's enough. I'm going to stop there with the quotes and just talk about some discussion points here, some of which I've highlighted kind of throughout. But just one point that we also put in the title of the first paper that we wrote about some of this work is that rhetoric matters. And evoking fear within underserved communities only exacerbates barriers and historic distrust, undermining the efforts of health professionals to reach those that may need it most. And barriers to access can make other barriers more difficult to overcome. And this really ties to the theory of intersectionality, where it's harder when if you have great access to transportation and you don't have some of the other things that might help you access healthcare, well, that will help you a little bit. But the fewer of the things that help you access, the fewer of the social determinants of health, and if you're also experiencing fear, the harder and harder it becomes. And the less likely you are to build up a relationship, a history, a connection with a local clinic or a set of providers that you trust and you feel safe with. And then prevention doesn't happen as much. or mental health care doesn't happen as much. All of those types of things. And also members of mixed status families, where some have documentation and others do not, they can face the same challenges, as there is a fear of jeopardizing others within the same household or community or the neighbors. If someone starts to have information about you, then they want to know about the rest of your household. And if you have your papers, if you have your visas, you have residency, but others do not, your aunt, your cousin, your sister, your parents, it's another barrier for you to access because you're jeopardizing those that you love. There are some limitations to this research. We were really speaking to community health workers, these key bridge figures between underserved communities and the systems that they were where people try to access services, in this case, primarily health, as proxies about the experiences of their clients, rather than speaking with their clients themselves. Of course, that's very difficult. We've been speaking a lot about fear, and of course, having some academics from a university come into a rural colonia on the border, asking to speak with folks that may not have documentation, really would be a huge challenge. And so we were really hearing a lot of these stories from community health workers, but they're uniquely positioned because their work is to see how individuals work through bureaucracies, through accessing different types of services, and when they can't. In this case, the geographic focus was solely on Texas for this particular research project, where the governor's politics are very different than what you would find in California or other border states. And particularly, California is much more open and even has access to some Medi-Cal. It's very, very different climate than you find in the state of Texas. And of course, we had the general limitations of focus group and qualitative research regarding representativeness. We cannot claim any kind of generalizability from these data from the focus groups with the individuals that we met with. And also the data collection was from a few years ago, but as I mentioned, it may be very relevant again soon, as immigration is right now, I believe, being used as a political tool. So some of the implications that I've already discussed is that fear is an important barrier to health access. But I want you to think about how this barrier can be exacerbated when it intersects with other barriers too, the rhetoric of political leaders, historic distrust, or even a lack of comfort or ease of accessing services on a regular basis. The mixed status nature of families or not having residency documents yourself, and the powerful word of mouth spread of information and even misinformation through communities. The strength of social networks in spreading public health information in many communities should not be underestimated. But those same social networks can also spread fear. And sometimes, some of the quotes were about making the assumption that if you received a letter about deportation, it's because you had gone to a particular clinic the week before. That may not actually be cause and effect, but in this sort of world of fear, a lot of assumptions can be made and ultimately lead to people not accessing the healthcare that they need and deserve. And of course, laws like Senate Bill number 4 could have a huge impact on fear everywhere throughout the state of Texas, making sanctuary cities a thing of the past, and also sending a lot more individuals back across the border. And we've discussed a little bit earlier from some of the work that I did with Doctors Without Borders, just how bad that can be as well. And I want to leave you with this point before we go to questions. Barriers are easy to create. It's really tearing them down takes a lot of time. And we should focus our efforts on helping to grant broader access to health and to build trust where it's been lost. And that's a long game. That is a long-term, really working towards sustainable long-term access. You have to build trust. And I personally believe that community health workers are uniquely situated to be key figures in the building of that trust with underserved communities across the United States, and in this particular case with Latinx families in Texas, and especially those that are in mixed status families or maybe don't have documentation at all. All right, and with that, I will leave probably more time than we'll need for questions, but I wanted to try to get through in 40 minutes. I think I did it in 37. So I'd like to thank you and open it up for questions. Also, my contact information is there. If you are interested in reaching out, I would be more than happy to hear from you, set up a Zoom call. or discuss some of this research. I haven't been doing as much research recently because I'm directing an MHA program at the moment, but this is something that I'm passionate about and I'm looking into with some of the Latinx communities in the New Orleans area. I would like to look into doing some additional work on access here in New Orleans. There's actually a very large Honduran population in New Orleans. And I lived in Honduras for over 2 years. I actually just met somebody down the street when I was walking my dog who is from the same community that I lived in 20 years ago, a town of 3,000 people. So it can be a very small world. But I will stop there and open it up for any questions, or everybody can go grab some more lunch.
Thank you so much, Dr. Washburn, for that amazing presentation. We do have a question already in the Q&A. Do you think this fear can be reversed?
So it's yes, but not quickly. It requires a different kind of leadership at the top. I think it's going to require somehow immigration to stop being used as a political football. When the politicians get involved, everything just, we lose track of science, we lose track of rationality oftentimes. But it would take a long and just very proactive effort by community members, by people that are like CHWs who already have trust in the community. But then there couldn't be sort of all of these other additional failures along the way. Every failure just leads to more fear and more distrust. And when you're threatening people with deportation after they've been living in a particular location for 20 years, I mean, what could be more that would create huge amounts of fear? So it is incredibly multifaceted, and I think it probably would take decades, quite frankly. But we need to start moving in that direction and not the opposite, in my opinion.
Thank you. We have another question in the Q&A. Melissa asks, what recommendations would you give for sustainable CHW funding mechanisms?
Yeah, so the good news is I feel like we're starting to see more of this. We actually see healthcare systems starting to hire more CHWs because through the Affordable Care Act, and even through some of the payment mechanisms that were reimbursement mechanisms we're seeing in the US healthcare system, hospitals are being incentivized to care more about wellness and keeping people out of the hospitals and keeping people and helping people address the social determinants of health and not just sick care. And so in some focus groups that I was doing in Boston at the Boston Medical Center, which serves a lot of the under and uninsured in the city of Boston, they had hired a number of community health workers to work with people that were frequently using the emergency departments for their care, which is very, very expensive, and it's not particularly proactive. And a lot of the CHWs were saying, hey, but if you don't have a home, or if you don't have transportation, or you don't have the resources to get your medication, how can you take care of your diabetes on a day-to-day basis? So there's a greater recognition. I think with more research on the impact and the effectiveness of community health workers, we'll see more hospitals get into this and get the notion that, we're actually having our social workers do very different things sometimes nowadays. And we're missing out on this navigation component and the addressing the social determinants of health outside of the healthcare component. So I think we're going to see in one place hospitals hiring more CHWs, and another place, I think insurance companies are incentivized to see more CHWs working out across the country. Because why? Because if you keep somebody healthy and you help them to sort of navigate systems and seek care before problems become too grave, then you avoid all these expensive hospital costs. So insurers then don't have to pay out as much to the hospitals. So they also have an incentive to see more. And so I think we'll see some grants that come, from the federal government. We already do see grants. We'll see some more grants, and there have been some where insurance companies are really trying to push for more CHW involvement. So it's, step by step, I think we're getting there. I think we're further along than we were when we did this legal analysis a couple of years back, but there's still a lot of work to do.
Thank you, Dr. Washburn. We have two more questions. Next, Kizzle asks, do you think there is room to implement free clinics or something similar in border towns to mediate some of these barriers?
Yeah, absolutely. And there are some very low cost providers of care and federally qualified health centers that do provide wonderful services. And there are a lot of clinics where they won't do the types of things. They know very well not to ask for certain types of documentation when clients come to see them in a lot of the clinics that are really there to provide care for the underserved. So absolutely, I would love to see more of these. I think facilitating cross-border travel. I've traveled back and forth across. When I lived in Mexico for about 3 years, I traveled back and forth across the border a couple times. And as soon as you cross the border in places like Laredo and Nuevo Laredo, there are pharmacies and doctors and just a number of healthcare providers as soon as you go south across that border. I think facilitating that, making it easier to access. Of course, I already discussed how documentation makes that very improbable for a lot of people, but free clinics, a lot of the work that the FQHCs are doing, and then also facilitating all of the access to all of the care that exists just across the border, where an MRI might only cost you $100 or something dollars, where if your insurance in the United States, you'll have to pay way more out of your own pocket, even if you have insurance for the same type of thing. So the supply of care, I think, even if it's not right now in the colonias on the border, it is in some of the cities on the border. They're also right across the border. There are so many opportunities where I think we could really see better access for people if we were able to get through and sort of the documentation issues and the problems and the walls, that actual physical walls and barriers create.
Thank you. The next question is, what was the most challenging experience when gathering the information/quotes from the participants?
Well, one thing is, there's a word in Spanish that I really like that I don't know that there's the exact same sort of definition of word in English, but in English it'd be trust, but in Spanish it's confianza. And anytime you're doing qualitative interviewing or interviewing even key stakeholders, you have to build trust with also the respondents that, here comes this guy from Minnesota, speaks Spanish, but, and he's here in a colonia to talk to 20 community health workers or however many there were in that particular day, and ask them about sort of their experiences. And qualitative research it can be a challenge because you're starting with a group of people and you're trying to build that trust, and you're trying to get things rolling. But what you really want is the rest of the focus group to start building off of one another. And when they start sharing their experiences, that's when you start to hear some of the really impactful stories. But that's always a bit of the challenge when you're doing that kind of research, and also just even connecting with the right groups to be working with. We worked a lot with the National Community Health Work Training Center to identify where are different groups of community health workers, and all those logistics can also be very, very difficult to work out. Then, of course, there's the travel, but it's also just really engaging. It's a great engaging experience, and something that I'm very passionate about. And I also really like primary data collection, and you have to be in the field to be able to do that.
Thank you. We have another question. I grew up in McAllen through the 90s until 2012, and there was much less fear in the community then. I hope that as a CHW myself, I will be able to help make a difference. In what ways can we gain trust back in the community as individuals who want to help? Boots on the ground?
Yeah, I think, boots on the ground, more that outreach component, especially when so much of that trust has been lost. And also thank you for your work as a CHW. That's great. And it's horrifying to hear how back up until 2012 and then a little bit later, how McAllen was just this. It's a town where lifebloods of economies are coming through there with the amount of freight that goes back and forth across the border every day, and all the positives of the economic interchange that happens. It would be great for that not to be a place of fear. But I think it's outreach, but you also we need to stop having this kind of rhetoric at sort of the top political levels of the country, because that's going to have an impact no matter what you do at the ground level. So it has to be sort of a multifaceted approach. I think as an individual, like myself, it's to, help still discuss these issues, or as a CHW to go out and to be out there at the health fairs, to be, discussing these very complex issues with the community too. And not just saying that there shouldn't be reasons for fear, because there are, but also talking about ways to address them. Boots on the ground. I think you had the answer in your question, and it's that communication, the building of trust, and the good news is that I think healthcare systems and insurance companies, and there's a greater awareness about the incredible value, and not just because it's a human right issue, but also, insurers and healthcare systems are worried about money too. And quite frankly, these things are lining up in terms of being the right thing to do and being good for the system. So I think if we can build this inertia, I don't know what to do about the politics. I'm gonna leave all that. That's way above my pay grade. But working with healthcare systems to recognize the importance of CHWs, and then also for having those meetings, the outreach, the here in New Orleans, West Jefferson Hospital opened up a Spanish speaking clinic just in the past year, that one of the doctoral students at Tulane was really helped to sort of program that out with a local Spanish speaking provider who was originally from somewhere in South America. I can't remember exactly where right now. But as soon as that clinic is opened across the river, on the West Bank, they have wait lists. People are coming and they're realizing, hey, this is a place for us. And I think those types of wins, if you can build those and then replicate them in other places, you can start to regain some of that trust. But that requires outreach, that requires getting the word out there, and having also these types of places exist where people can be comfortable and they can speak with providers that have credentials in being able to speak medical Spanish even. So there are lots of things that need to be done. Hopefully they could all happen at the same time so that we can start breaking down some of the intersections of all these different barriers. But it is going to take time. I'm putting my optimist hat on. I like the fact that systems like LCMC and West Jeff opening up a Spanish-speaking healthcare center, and the fact that insurers in the state of Massachusetts are also investing in projects where CHWs are really part of going out and addressing social determinants of health for underserved populations. I think we're seeing some innovations and some really wonderful things happen. And I just hope the politicians don't screw it all up. I shouldn't have ended on that bad note. I have a little positive note going there for a little while, but
Thank you so much, Dr. Washburn. That is it for our questions. If no one else has any other questions to drop into the Q&A, we'll give you back about 8 minutes of your day.
Well, thank you all very much for attending. I really appreciate your questions, and hope to see you here or hear from you around Tulane. Thank you all.